Is my audio clear? Can you hear me now? Hello? 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 Yeah?
Hi, Pauline. Hi.
Good morning, Dr. Clement. Hope I'm audible.
Hi.
Hi, Dr.
May I try to share the slide and see if you could?
Yes.
Okay. Is my screen being shown? Is my screen being shown?
I'm not able to hear you.
Sorry? Is my screen being shown? Being shared?
Your slides are visible, but
Yes. Yeah.
I'm not able to hear you.
Is it moving now?
Your slides are all visible, Dr. Clement.
Not visible.
It is visible. Your slides are visible.
Okay, maybe I shared the wrong. I'll share again. Mm,
Just hold on, Dr. Clement. Just a minute.
okay. May I share again?
Dr. Clement, could you speak now?
Yeah. Is it clearer now?
Still not audible.
Is it clearer now? Is it clearer now? Hello. Yes. Hello.
Yes, Dr. Clement.
Okay.
Yeah, now
So,
it's fine. Now it's fine.
Yeah.
Yes.
Okay.
Thanks
May
a
I
lot
share-
for joining us.
Okay. Thanks.
Yes, thank you.
May I share the screen? I mean, as in see if it's doing fine.
Yes, Dr. Clement. Yes, please.
Okay. So I'll just share the as in just share the slide. I mean the PowerPoint show. only.
Yes, please. Yeah.
Okay. So it's my slideshow being seen.
Yes.
Okay. So is it advancing?
Yes, Dr. Clement.
Okay.
Yes,
Okay.
it is.
Okay. So I'll stop sharing now. Okay.
Thank you.
Yeah. Welcome. My pleasure.
Yeah.
So are you going to give any talk during this?
No, it's just for the keynote speakers.
Oh, I see.
Participants have already started joining.
Okay.
Yeah.
Good morning, everyone. We are glad to have you all here for the first keynote session of Day 2 at the 8th International Conference on Biosignals, Images, and Instrumentation for the year 2022. I would like to extend a warm welcome to our first speaker for the day, Dr. Clement Yun from Nanyang Technological University, Singapore. Dr. Clement Yun received his Bachelor of Engineering and PhD degree in Electrical and Electronics Engineering from Nanyang Technological University, NTU, in Singapore. He is a part-time lecturer in the School of Chemical and Biomedical Engineering at NTU. His research is focused on surface-enhanced Raman spectroscopy and other imaging techniques for biomedical applications. He was the recipient of the Mistletoe Research Fellowship, Liu Kuan Yew Postdoctoral Fellowship, and Agency for Science, Technology, and Research Graduate Fellowship. He was also the former founder of his own startup company. His research outcomes include 1 US patent and 3 invention disclosure, 1 invited book chapter, 32 international technical journal papers, and 24 conference papers. Moreover, his test kit for malaria received interviews by the Channel News Asia and a series of other media, including Phys.org, ScienMag, and so on. His microneedle-based enhanced Raman work has been featured in Advanced Science News and the Editor's Choice in Journal of Biophotonics. We are pleased to have you today, sir. I now welcome you to begin today's session.
Okay. Thank you, Rebecca, and very good morning to everyone. So I'm going to share my screen. Yeah. First of all, I would like to thank the conference committee, all the chairs for inviting me to present here, and especially Pauline for allowing me to speak here. My name is Clement, and I'm from NTU, Singapore, School of Chemical and Biomedical Engineering. And today, this work is also from my past group leader, Professor Liu Quan. He's now in Xiamen University, China. And today's the title of this topic is Surface Enhanced Raman Scattering for the Detection of Hemosone and Malaria Diagnosis. For the simplicity's sake, throughout the talk, I would refer Surface Enhanced Raman Scattering as SERS. So for this slide, I'm going to talk about what I'm going to present in this presentation, and you have a rough idea what is going to go about next. So first will be the background and motivation of this entire research, and then will be the 4 blocks here will be the timeline from our start of our research and then until the end where we are. So for the first 2 will be mainly more of feasibility kind of studies and works to examine whether this SERS technique is worth for us to move on and do some deep dive and deep study into the study of infected malaria blood before we go any further. So for these 2, we are just making some chemical equivalent before we are still not yet moved into the infected blood yet. Whereas the third one, we are using the infected blood for measurement, and all this will be done in the laboratory. And then finally, the diagnostic chip will be more towards field diagnosis, more point of care without the need of lab environment. And then finally, I'm going to give a conclusion on everything. First, for the background and motivation for the this malaria disease, of course, is a mosquito-borne disease, which is caused by this guy here, the mosquito. So if, let's say, a person is being bitten by a mosquito with this protozoan parasite, then it will get infected. And that if this infected person is bitten by another mosquito, and then this mosquito go to bite another person, then the other person who is not infected will also be infected by the malaria disease. And that for this disease, malaria disease is a worldwide disease, and that in just last year, it causes 6 to 7K deaths. Although the number is not a lot, but it's like every minute a person will die because of this disease on average. So the talk, I guess roughly the talk until this point is almost 4 minutes. So 4 people already died because of this disease. For diagnosis of this malaria disease, the gold standard by the clinicians is using the microscope examination of blood smear. So it's like the first drop of blood, we don't know whether it's infected or not, will be dropped onto a microscope slide. So, and then it will be spread to be a very thin layer to make a blood smear, and then it will be stained, and then after it will be wait to dry and wash. Following that, will be put onto the stage of a microscope, as shown in the figure here, to see if any of the blood cell is being stained, like what we are seeing here. If it's stained, then we can say that the person is kind of infected. But this whole process is quite time-consuming, and that we also need a very skillful worker to perform all these tasks. And why I would say that is very time-consuming. If, let's say, the whole microscope slide is to be have only one stained blood cell, and then because of the field of view of the microscope, you would take a long time, or the expert would take a long time to search through the entire microscope slide to find the one and only infected blood cell. So it's very time consuming, and it also depends very much on the time and the skill of the one who is checking. So because of this, there are a lot of research ongoing, and that there are many different types of methods as shown in the table here, and that most of these techniques will be try to make this diagnosis to make it as fast as possible, and to try to do early diagnosis. Why we need early diagnosis? Because this malaria disease, the disease progression is very fast, which means that from the first symptoms appears to the time of death can take a few hours for very severe case. So it's progressed very fast. So in order to prevent any morbidity and any deaths and lives lost, we need to make it fast and early, way before the symptoms appears. But of course, if we need to do it early, the biomarker will be in a very low concentration. And because of this fact, we need sensitive methods to do all this. That's why we are showing this table here to list out the various type of a few examples of the methods used and researched in this area. I'm not saying by putting here which technique is better than which one. It's just that in this aspect, when we are looking at the detection limit, these are the numbers. And that I would say that each techniques have their own advantages and disadvantages. Some maybe take a long time, some may be faster, some has a high false negative or false positive rate, and then some may need very expensive equipment, and so on and so forth. Some will be very convenient, and each have their own advantages and disadvantages. And of course, among all these, Raman spectroscopy have a very potential prospect in this aspect. I'm not going to say much about Raman. I'm happy to talk to people from India, because you all will know who is Sir C.V. Raman and know what is Raman spectroscopy. And that, of course, this method is very fast, and then it does not need a lot of people to do it. And then it's also not skill intensive. And but for Raman, the signal will be weak for those endogenous biomolecules. So in view of that, our group, we are looking into methods to enhance the Raman signal. So what we have been doing is that we investigate on this surface enhanced Raman spectroscopy, also known as SIRS. With this technique, there will be signal enhancement, which will be in terms of electromagnetic and chemical enhancement. So the enhancement will be both in the excitation electromagnetic field, which will be increased by its magnitude square. And at the same time, the Raman scattered electromagnetic field will also be increased by magnitude square as well. So in total, the enhancement factor will be kind of like increased by to the power of 4. So it's increased by a very high factor. Okay, so also this technique enhancement is also possible even if the enhancement molecule, that is the SIRS nanoparticle, is not in contact with the analyte molecules. So in fact, to put it simply, what we are doing is we are trying to make nanoparticles to enhance the Raman signal detection from the analyte molecules. So that we are trying to analyze the analyte molecules as shown here in this figure, but we are introducing the SIRS nanoparticle to increase the signal given out by this analyte molecule. We are not analyzing the SIRS nanoparticle, because in some of the presentation that I gave, some people will misunderstand that we are detecting the SIRS nanoparticle. So we are detecting the analyte molecules, and that the SIRS nanoparticle is those that we are trying to increase the signal, used to increase the signal. So our job is to bring these two to be close together. As we see, the closer we get, the stronger will be the enhancement, as shown in this drawing here. For using this technique in our malaria studies, before we, as I have mentioned in the outline slide, before we go deep into investigation for studying the infected blood and so on with SIRS, before that we do some feasibility studies. We are not using the infected blood yet here, but we are trying to make biocompatible equivalent, or rather chemical equivalent of this biomarker that is typically detected in malaria disease. That is Hamilton. Hamilton is the biomarker that we are typically detecting in this malaria disease. We make this chemical beta-hemethine. So as we can see from this figure and the results here, we can show that the beta-hemethine crystal that's fabricated by our group is in size and in shapes is very close. It's look alike to that reported by the literature, the Hamilton biocrystal that is found in malaria disease, and also chemically is almost the same as that of Hamilton in the Raman analysis. For here, we are still not using enhanced Raman yet. It's just a conventional Raman. For here, we move on, and then we introduce this and we propose this magnetic field and enriched source. Why we are doing this is because of the fact that as we have seen from a few slides ago, we know that the closer between the analyte particles and the source particle, the better will be the enhancement. But this will not be the case for those beta-hemethine analyte, or maybe even in the Hamilton crystal that we are going to do later, because the size is very different from all those analyte molecules that's typically used in the chemical analysis, like maybe for those dyes molecules like rhodamin 6G and so on. Whereas those dyes, the molecule size is very small, and also the absorption, the binding between the molecules and that of the source nanoparticle is quite strong. So the distance between the two will not be a problem, and the enhancement will not be a problem. And because of that, we need to use some method to enhance this this binding and to make the technique more sensitive. So we can see that for our experimental results in B and C, we make use of this magnetic field with and without magnetic field. We find that with this magnetic field, by having this this special structure for the surface, I mean the source nanoparticle with a magnetic core inside, and then apply a magnetic field, we can bind better between the the analyte molecules as well as the source nanoparticle, because the analyte particle is by itself is paramagnetic, and this is also the case for beta-hemethine and Hamilton as well. So that's why we propose and introduce this method to use magnetic field to kind of increase the signal, and also to enrich the concentration of both the analyte particle and the source nanoparticle in order to give a better signal. As we can see here, with the magnetic field, the detection is very much more sensitive than that without the magnetic field, and that the concentration can go down even to the -9 molar kind of concentration, which if we convert back that to the number of parasites that we can detect in microliter, would be 30 parasites per microliter. And to give us a sense in comparison to other methods. For microscope detection technique will be about 20 to 50. Really depends on the skill of the microscopist. And then for rapid diagnostic test kit will be about 100. So it's a very good improvement when we use this technique. So in a short summary is that we have demonstrated the feasibility to use SIRS on beta-amytin with this special particle with a magnetic core and then a silver shell, whereas the silver shell will be doing the job of enhancing the signal, and the magnetic core will be doing all the magnetic enrichment. So we do this further, we even achieve a further enhancement with this magnetic field. And also we show that this technique is potential for malaria diagnosis. And then although the timeline here is in sequential manner, but of course for some of the tasks, we do it in parallel and at the same time. So at the same time, we also did some optimization of the size and then all the parameters of the structures of the SIRS nanoparticles. So we studied the different sizes, the numbers to be attached, and then also the spatial arrangement of all these particles. How about, I mean, also as in if we have a thicker shell and then also a different size of a diameter, what will be the performance of the enhancement effect, as we see here in the figure here on the right. Figure A and B will be, we are studying on the size effect. All these are just examples. We have done quite a few other than all these. The electromagnetic field intensity here, the magnitude here is kind of like an indication of the intensity of the Raman enhancement that it will give in the experiment. And then for C here is we are studying the extinction efficiency. So what is extinction efficiency? Is that is the absorption and scattering coefficient of the SIRS nanoparticle, the particle itself, the enhancement particle itself. And that we are studying the different configuration, as in how, if let's say there's only one nanoparticle, what will be the performance of this nanoparticle? If two are sticking together, they call this dimer. What will be the performance in a linear manner? What will be like, and so on and so forth. And then the wavelength means the excitation wavelength, at which excitation, that is the laser used in the laser wavelength of the Raman, which is the best. Which one is the best? The higher the excitation, I mean the extinction efficiency, the better will be the performance at that particular wavelength. So after we choose that particular wavelength, then we try to vary we fix the wavelength, then we study the variation of core size and then shell thickness in order to see which parameters will give a better result of the Raman performance. Of course, apart from this simulation studies, we have done experiment to validate whether this is correct. And then we fabricate the different types of size of different magnetic core. And then also we have fabricate the nanoparticle with different shell thickness. So for here, the letter C will denote what is the size of the magnetic core radius, that is the iron oxide, and then Ag is the silver, that is the shell thickness will be denoted by S. that is the silver, which is doing all the surface enhanced Raman enhancement. And that so we find that the best will be the one with the radius 25 nanometer and shell thickness of 45. So this is kind of like, if we look back, there's a bit of maybe discrepancy between the simulation. So the simulation may be somewhere here may be best. And then the experiment maybe is here is best. The discrepancy may come because of the number, although in here the larger will be the better, but of course the larger, as we look at this, what we have been simulating above in A and B, as the nanoparticles go bigger, the number then can be attached to this biocrystal become less and less. So it's like a trade-off between the size and the numbers that we can bring to the analyte particle. So in a short summary for this optimization, we have kind of optimized and investigate this magnetic field enriched search strategy in terms of the silver surface active, the search active layer thickness. And also we have also investigated the iron oxide core radius size, and also look at the electric field distribution, extinction efficiency, and so on, in order to give the best results for search enhancement for our purpose. So this will be, these two, the magnetic field and research will be more or less cover the feasibility studies, and that we are comfortable, then because of that, we are comfortable, and then we moved on into the infected blood study, which is the detection for the real biomarker hemosone in the parasite inside the blood cell. Of course, everything is not as smooth as what we have predicted. There will be some hiccups, and what will be some of the obstacles that we need to overcome in order to move on is that we can see that for the biocrystal for detection in our method is that we are detecting the hemosone as shown in this figure A here, this figure here, and that the hemosone is this cartoon here. The hemosone is inside the foot vacuole, inside the parasite, and then inside the red blood cell. So it's wrapped by a few different layers. So before we get to the hemosone, we need to first break down all this layer and then go to the biomarkers that we want to analyze. So if we just put the mix the search nanoparticles with what we have in the previous research, that is, we apply the magnetic field and use the nanoparticles. This is what will be resulted in this small figure here. Only the search nanoparticles will be attached to the outside of the red blood cell, or maybe some maybe get closer, maybe because some of the red blood cell could, if it's lysed, so that's not desirable. So we need to think of some method to make the detection to be sensitive and effective. What other people do is that and also this is what conventionally people will do, is that they will lyse the red blood cell or the blood cell, and then to lyse everything, and then to extract the hemosone. So after the extraction, they'll do a centrifuge, they'll do filtering to make it cleaner, because all those debris from the lysed cell will still stick to the hemosone, and that in order to concentrate and purify the Hamilton crystal. And aside this, they will separately prepare the source nanoparticle. They will make the source nanoparticle separately, and then they mix the two together to perform the source measurement. This is not that effective. We have tried it out because of the fact that during the concentration process and filtration process and purifying process, some of the Hamilton crystal may be lost, and that also at the same time, some of the debris may not be cleaned very effectively and still leave on this residue or the analyte here, such that during the detection, we still detect some of the signal from those unwanted stuff. So one thing is that it will enhance everything. So whether it's the thing that you want to study, it will enhance. All the noise will also enhance as well. So it needs a very particular environment in order for it to work out. As for our group, it's like we did this. We proposed this. We try to make the source nanoparticle together with the blood. So simply put, is that all these chemicals will kind of like diffuse into the membrane. We hope that it will diffuse into the membrane, and then eventually the nanoparticles will be formed in this inside the cell, or at least it will be much closer than we are just doing just a simple mixing of the two together. So this is the result. It's very good that we achieved this in the sense that the nanoparticle is indeed get close to the biomarker, and it's shown here. It's like it get close to the DNA rings of the parasite, and that it gives a good result in the sense that because the nanoparticle can get close to the biomarkers and give a good enhancement, as shown by the red curve here, the red spectrum here. This is done by the method 2, our method that's making the nanoparticles together with the blood. And in contrast, for that method 1 will be the one above by this reference 10. It's just extract out the Hamilton and then do a measurement. So we convert all the concentration and all that, and we find that we can even achieve sort of like to detect 2.5 parasites per microliter in this proposed technique. And as compared to that, for those, if we just mix the nanoparticle, extract the Hamilton, and mix the nanoparticle with the Hamilton, we can only achieve about 500 parasites. So in conclusion, is that we achieve sensitive surface detection for Hamilton. So this is good enough for early diagnosis, and that because it's achieved a detection limit of 2.5 parasites per microliter, and then we can make the such nanoparticle to form close to the biomarker and simplify a lot of things, because we don't need to lyse the cell, to do the extraction, concentration, and also some of the equipment is being eliminated, like the centrifugal machine. And because of that, we move on and we try to eliminate everything. I mean, as in, we try to move on into, we try to do all this into the field rather than doing this in the experimental lab, as what is shown here. This is what the previous method, how we did this, and where we done all that. this is A is our lab, so it's we need this lab environment to prepare all the nanoparticles where I prepare the chemical particles in the film hood C, and some of the equipments like the sonic heater, and finally we bring all those into the famous Raman machine here, invented by Sri Raman. It is quite huge. It occupies the almost the entire room of the lab. So it's not very convenient if we need to do this in the field. We need to bring all this to the field. It's almost impossible. And also for malaria disease, it typically happens in those countries where those countries will be isolated, and the resources will not be very to be efficient for doing all that in the search performance. So it's difficult to perform field analysis in all those countries and perform this field analysis. So what we do is we are having this, we are making this. This is our proposal, and that. So what we do is we drop this drop of blood, mixing with water, and then we drop into the inlet of the chip, and that inside the chip there are all these chemical patches, as illustrated by the different color patches here. Those are dry patches. So after that, the blood will run through all these patches, and as it runs through, nanoparticles or chemical reactions will take place, and then eventually nanoparticles will form at the end. And this is very similar to what we have done in the lab in the previous work, and that again, we hope that the nanoparticles will be formed close to the biomarker in this case. And following that, subsequently, we excite laser, or we place that into the Raman machine and then do the Raman measurement. So we excite the laser light, and then we collect the signal from the same location as we've shown here. And then we are happy that we can kind of get satisfying results, and to detect the Hamilton inside the chip, and that the figure here shows the malaria infected blood at different parasite level. That what this means is Hamilton parasitemia level is that different numbers of parasite inside the infected blood cell. That is a different concentration of parasite. So we can see that we can even detect down to this concentration, which is about 1 to 5, and that we make use of this particular peak as shown by this dotted line here to do the detection and identification. Although there are many other peaks from the Hamilton biocrystal, but we make use of this peak because of the fact that there are also other characteristic peaks from the other components inside the blood cell. We find, and we are using this because of the fact that this peak is not that close to other particular peak, in fact, influenced by other components, and we make use of some mathematical method to separate this intensity here and the magnitude here, and then we can make use of the strength of this peak, or the area under this peak area here, to decide how much this concentration is inside the infected blood. So for this graph, the gray curve is the studied at a different location for the blood and the different sample to do repeatability test, and that for this number is understand that is a bit is larger as compared to what we did in the lab, but because we are making use of a much more compact Raman system as what we had before, as what we shown in the previously, that the Raman system is occupying another room. This Raman system is 10 to 20 times smaller than the previous one. Is more or less like the size of a desktop computer. So it's more mobile and more feasible for field analysis as compared to the one that occupy almost a whole room. And also for the fact that this more compact Raman is again 20 to 10 times more cheaper than that of the more larger system. And because of that, and also for this more compact Raman, because of the laser wavelength is different because of the model and the specification. The wavelength, excitation wavelength is kind of different from that of the original one that we use. But based on the calculation, just calculation, if we can find a model, if we can find a model that's having the same wavelength, we can bring this number further down to 3 times smaller. So again, we further optimize this method. We can assure that we can get the detection limit to be lower. So it's quite promising for using field using this in field analysis, because for each of the chip, also is the price the price that we need to make the chip is very inexpensive. It's only about $1 US per chip, so it's very compatible to other rapid diagnostic kit, and that's maybe as given here, they detect about 200 parasite per microliter, and then for us we can quantify to decide how severe is the case, and then for them it's like they don't have quantification. But of course, I would like to say that it's still a long way to go. For the compact Raman system is still not as small, as in it's still the size of that desktop computer. But I believe that there are still other like other more complex model like handheld and all that. We are going to try all those, and at the same time we are also making our own cost-effective Raman system, which is more mini and compact and more effective to do all this. And hopefully by then everyone can have one at home to check them themselves. So in conclusion, so we bring everything to the field at the end, and then we achieve service-based malaria diagnosis on the fluoridic chip device. As shown here, the photo here is the device size. Each square is 1 centimeter by 1 centimeter, so the chip is not very huge. And then you can see that the material is not expensive. It's very simple material. It's just plastic and aluminum foil and all that. So it's not expensive. It's $1 US per chip. So we have synthesized such nanoparticles. We can synthesize all those nanoparticles in the field. And then also we also solved another important question in the SIRS arena, is that for SIRS nanoparticles, the shelf life is typically not very long, like 3 months, 6 months, and not very long because of the oxidation of the metal, and also maybe some contamination. So we, as compared to all the rest in the that are available in the market, we make the nanoparticle on the spot. That's why we don't have any issues of the shelf life. The shelf life will be decided by the shelf life of those chemicals. Like if we are using sodium dioxide, so it will be decided by the shelf life of sodium dioxide, which is much more longer than that of the ready-made source nanoparticle. So this will be commercially viable and sustainable if we are going to sell this. And of course, the lab environment is not needed in order to prepare all those. And at the same time, for the operator, I mean, when the operator get this chip, the operator does not need to mix the chemical to touch all those chemicals which are quite toxic. So it's safe to the operator. And also at the same time, we are using a more compact Raman model. So it's few and on the spot diagnosis and operation possible, and it's cost effective. And in conclusion, we have went through all these what we have done in our lab, and that we have realized and demonstrate SIRS-based malaria diagnosis. Using this SIRS method is not only fast, but also it does not need much labor, very skillful labor, and that it's a sensible and sensitive strategy for detecting early malaria disease, and that is potential for field use and also point of care operation without the need of a laboratory environment, and that is promising to be commercially viable, scalable, and feasible, as what we have said just now. It's not expensive, and it has a very good selling point as compared to others in the market. And that, of course, my dream is that I want to make this Raman technique to be cost effective and very efficient. And I hope in future everyone in our home can have a Raman system, so that we can detect not only malaria but maybe other disease as well, to improve our health. But also, okay, this is towards the end. I would like to thank, of course, Professor Liu, who is the leader of our group, and that all other undergrad, master, and PhD students who took part in this research, and also all other members in our lab for their precious discussion and valuable inputs, and all other researchers and expertise and other well-known professors in other groups who collaborated with us. And also I would like to thank Lee Kuan Yew Postdoctoral Fellowship and Mr. To Fellowship for sponsoring me to doing all this. And then thank you. And then last but not least, because I'm sort of like a reviewer board for this journal, if you're interested, you can check out more by looking into their website. And then there are special issues in this journal. They want to invite people to submit paper on these topics, and also for this journal as well. You can go to their website. They have this nano sections here, nano sensor section here, where they have, again, they have quite a number. I'm not going to show all those special issues here. You can go in and have a look. It's quite a lot. You can submit and see which one will be interested to you. Okay, thank you. Thank you very much. And that's all. I will open up for any question.
Thank you, Dr. Clement, for the detailed talk. Thank you for accepting this invitation. We look forward for more collaborations in future.
Yeah, definitely. In fact,
Yeah.
it's my honor to come to the talk.
Thank you so much. Thank you so much, Dr. Clement. Now over to Rebecca.
So before we end the session, we would like to play the video with your permission where CNA broadcasts your work.
Oh, sure,
So,
sure.
yeah?
Okay.
NTU develop a test kit for malaria that delivers results in 30 minutes. For a closer look, we're joined now by the lead of this project. He's Associate Professor Liu Chuan. He's from the School of Chemical and Biomedical Engineering at NTU. Good evening, Professor. How accurate is your test compared with current diagnosis methods?
Well, since our test kits have not been clinically tested so far, so in this case, it's really difficult to tell how accurate our test kit is compared to other methods. However, so currently we're trying to improve the sensitivity of the method. So we're trying to do that such that it can outperform other similar kits.
Professor Liu, we understand it can determine severity of the infection as well. Tell us why that's important.
Well, the severity of infection for a malaria patient is strongly correlated to the degree of illness. So you can imagine that in this case, it can affect the treatment plan of the patients. A patient with more severe infection will justify the use of more expensive anti-malaria drug. All right, so that actually comes into the play of the treatment plan. Right? That's why it's so important.
Professor Liu Chuan, you mentioned there that other test kits have, of course, been developed elsewhere for malaria, but this one does away with the need for complex lab equipment. Can it work in the field with less than ideal sanitary conditions?
Yeah, that's a great question. That's a very good question. So it's so important to do it in a low resource region. I think our test kit has some certain advantages to be used in such a low resource region. So first of all, our chip contains all dry chemicals. So it's easy for transportation and a long-term storage. And second, it requires a tiny amount of water. So each test only requires about 10 microliter water. So now eye drop bottle can actually hold around 10 milliliter water. So water in an eye drop bottle can easily be used for around 100 times tests. So I think our test can possibly, very likely can do it.
And Professor, what's your next step? What specific areas are you looking to improve?
Well, first, we want to further improve the sensitivity of the kit by a few more times, since there are so many factors that are not optimized yet. And after that, we'll develop a cost-effective chip reader such that it can be used in the field. And this reader should be reusable. And after that, or at the meantime, we will want to work with malaria clinicians in the related countries such that they can provide us the feedback on what we need to pay attention when we manufacture those things. And we will also work with industrial partner to check all the manufacturing issues.
Let's talk about timelines, Professor Liu Chuan. When will this be ready for the market? How much more refinement does it need? And where would you anticipate that you will deploy it first?
Well, we're looking to improve the sensitivity and develop a cost-effective reader. So it will take maybe another couple of years. So I would imagine potentially it could be deployed in the field for the next in the next few years. And then we would expect to develop to deploy this in Southeast country. A South Asian country first, such like Thailand or Myanmar. And after that, we'll move to Africa. That's where the malaria is most prevalent.
Professor Liu Chuan, we wish you all the best with the continued development of this important test kit that you've created for malaria. We've been speaking there to Associate Professor Liu Chuan from the School of Chemical and Biomedical Engineering at NTU here in Singapore.
Dr. Clement, would you like to add a few more on the same, if you wish to?
Yeah, in fact, yeah, I would like to thank everyone again for inviting me to this talk, and also thank the committee, conference committee again for having me here to giving this talk. Yeah, that's it. I have nothing to add.
Thank you so much, Dr. Clement.
Thank you.
As we bring this keynote session to an end, I would like to thank Dr. Clement Yun for helping us to understand the motivation behind the research, showcasing the overall development of your solution, and explaining the hemazoin biocrystal detection for the early yet accurate diagnosis of malaria that can help save lives. Your presentation is indeed an inspiration to us all to identify clinical problems and to continually develop and integrate various techniques to create unique and effective solutions that is accessible and beneficial to all mankind. Thank you very much, sir.
Thank you. Thank you. Thank you. Thank you very much.
Thank you. So the next keynote session will be at 9:45. Those of you who would like to join in, please join the meeting at 9:45, or you can remain here. Our following speaker would be Dr. Neha Singh. Thank you.
I am pleased to introduce our second speaker for the day, Dr. Neha Singh. She is a research scientist in the Center for Advanced Research and Excellence in Disability and Assistive Technology, IIT Delhi, after completing her PhD also from IIT Delhi. Her interest lies in interdisciplinary research in neuroengineering for developing innovative rehabilitation strategies, biomedical devices, and its clinical validation, with a special focus on brain stimulation for neurohabilitation for patients with stroke. She has published a few international patents and copyrights. Her research area also includes biomedical signal processing, neurophysiology, and neuroimaging. We are delighted to have you, ma'am. I request you to kindly take over the session.
Am I audible?
Yes, ma'am, you are.
Okay. Thank you, Yamini, for the kind introduction and the warm welcome. I'll just share my screen. Is my screen visible?
Yes, it's
Yes, ma'am.
visible, Dr. Neha.
Okay. So a very good morning to all of you. I'm delighted and honored to be a part of this wonderful event, and it's my privilege to give a talk on my research on robotic exoskeleton for post-stroke neurorehabilitation. So just a brief introduction to stroke. It happens when blood supply to an area of the brain is compromised and neurons begin to die. And the functions which they were responsible for is also lost. According to ICBSII data, every 20 seconds there is a stroke in India, and every 2 minutes there's a stroke death in India. So stroke is an epidemic, and more than 80% of the people are having upper limb disability, and more than 80% of the people are living in low and middle income countries, where far less research has been dedicated to rehabilitation. In a country like India, where there are only 2,200 neurologists for a 1.3 billion population, Affordability, accessibility, and clinical load is a major issue and leads to unmet needs of rehabilitation services and a need of India-centric research. So when a patient is stabilized after stroke and he is shifted from ICU to the general ward, the aim is to promote recovery through rehabilitation, which is defined as relearning of the lost skills to regain the independence as much as possible. So apart from the brain stimulation techniques, various other rehabilitation approaches, or I would say rehabilitation strategies to trick the brain to learn are neurodevelopmental techniques, which is also known as physiotherapy, bilateral arm training, splints to avoid the contractures and the spasticity, mirror therapy in which the brain is getting the feedback of the affected hand moving via the unaffected hand. Also, there are various therapies like electrical stimulation, mental practice, biofeedback therapy, constraint-induced movement therapy, in which you can see this where the unaffected hand is constrained and the affected hand is forced to move for most of the exercises. There are also sensory motor training, virtual reality with multi-sensory feedback. There are various combinations, and as also the robotic devices are also there. So our focus was robotic devices. Most of the commercially available robotic devices are focused on proximal joints like shoulders and elbow, such as MIT Manu's Arm Guide, Needy Boat, Smart Arm, CPM, Continuous Passive Motion, BiManuTrack, MIME, Gentle. There are so many things. However, these devices mostly focus on the proximal joints rather than the distal joints, which actually contributes to activities of daily living. These all are devices which gives us enough advantages of robotics, such as specific repetitive training consistently without fatigue. And it also gives the patients the feedback about the performance, how much he has to try, how much more he has to try. And overall, this is all voluntary activated by the patients, like self-initiated by the patients. There are a few distal joint devices as well, like electromyogram, EMG-driven neuromuscular electrical stimulation, EMG-driven functional electrical stimulation. There is combo at L for wrist flexion and extension, in-motion wrist, hand mentor, etc. However, overall limitation of the devices remains the same. They all acquire semi-permanent space in the hospital. They are literally installed in the hospitals with dedicated trained staffs. They are obviously heavy weight, like the Columba is 40 kg and this in-motion wrist is 83 kgs, obviously not portable, and hence low accessibility to patient population is also there. These are highly expensive, such as the in-motion wrist is more than $40,000. This Columba et al. Is more than $25,000. So you see, this is all highly expensive. A very rarely talked about obstacle in the rehabilitation literature is multiple repositioning of the hand, because during the therapy, just an example, in India, there are only few robotic devices, centers, robotic facilities where we can get all these robotic devices, where we can count on the fingertips. Just an example, in Apollo Chennai, there's one robotic device, which is Armio. For 1,500 rupees, there is just 45 minutes of the therapy, and half of the time, the patient is doing the multiple repositioning only, because due to spasticity, the hand gets deformed. So he is paying more than half of the time, and like half of the time is going in the repositioning, and the physiotherapist has to intervene, defeating the whole purpose of robotics. Also, there's no home-based available device, and also there's no device which focuses on activities of daily living. Like there are devices, all these devices focuses on isolated joint movements such as wrist flexion and extension, finger flexion and extension. But in activities of daily living, there are movements which includes inter-joint coordination movement of multiple joints, right? So that's a very important missing point. To solve this, we did an observational study of 1 year in Department of Neurology, AIIMS, Delhi, under the supervision of Dr. Padma Srivastav ma'am, on 300 stroke patients. And what we observed was, since the patient was dependent on the family members for activities of daily living, there was a strong desire for distal recovery. And we also observed few patterns like clenched fist, contractures, pain. There was also patient-specific requirement like comfortable range of motion for different patients. So we also interacted with patients and family members just to get the user needs. What we observed was each stroke patient was unique, with a combination of clinical presentations depending on the area of the lesion, extent of the lesion, functions affected, age of the patient, chronicity, pain, spasticity, contractures. So you see there are various factors contributing to heterogeneity of the stroke. Hence, a rehabilitation strategies needs to consider this multifaceted nature of the device of the stroke, which itself changes with time, like acute, subacute, and chronic stage. The symptoms does not remain the same. So the device needs to be flexible enough to accommodate a large patient population. We also observed one of the most common clinical presentation, that is flexure hypertonia or spasticity. Spasticity is the rigidity or the involuntary contraction of the muscles. So it is flexure hypertonia is represented as flexed, bent elbow, flexed wrist, and fingers tightly closed inside. So you can imagine opening the hand and doing the activities is really very difficult for the patient. I'll just show you the video. So you can see how much is the effort required by the physiotherapist. Also, it is a very subjective and passive process. Patient will not get motivated to go to the hospital every single day of the life and leaving behind all the daily routines and jobs, etc. So this flexure hypertonia limits the activities of daily living. And we also acquired these forces at the wrist and the fingers joints required to move the muscles. We also identified the required muscle, that is the extensor digitorum communis muscle, that is responsible for wrist extension and flexion, wrist extension and finger extension. So we also observed that if you do such some activities of daily living, like holding the doorknob or holding the glass of water or eating or bathing, there is one particular pattern, which is wrist extension with a little bit of finger grasp. So this particular pattern is most common in most of the activities of daily living. So it motivated us to design robotic device to train in these movements like wrist extension and MCP, that is metacarpophalangeal joint, fingers joint synchronization. So coming to the development and testing, optimization of the prototypes. So I made this basic framework by geometrically constraining the joints, assembling the links, and deciding the lengths of each bar to achieve the desired range of motion of wrist. Here, the two joints movement, it would require like the wrist joint and the MCP joint, it would require us to have two actuators or two motors. However, with this 4-bar linkage, we can have just one motor, and the passive motion will be happening in the other joint also. So these were the basic prototypes which were developed. Finally, we came to the computer-aided design model and 3D printed it into the ABS plastic. And then each prototype was tested on the patients with feedback based on user needs, functionalities, design, and the hardware was also optimized with parallel to this optimization in the design. So this was the final prototype, CAD model of the prototype. You can see the movement here, the wrist extension and the finger flexion. So this is the joint which is wrist joint, and this is the joint which is the fingers joint. So with finite element analysis, we simulated the clinical data acquired due to the spasticity in the very first step, and we simulated it, and the factor of safety came out to be 3, that is making the device more robust. The factor of safety is defined as a standard measure of reliability of a particular design. So it came out to be 3. It means it can take 3 times the amount of force which is actually required for the movements of the spasticity. So the hardware was also designed with Atmega 328, and this PCB was inserted into the black box, which also acted as a user interface. This was just to isolate the patient from the PCB. And then this was the whole setup of the device, in which this is the EMG amplifier acquired. This is the EMG electrodes here. This is the mechanical design, and exoskeleton is there. And this is the performance feedback, which is directly proportional to the amount of the effort made by the patient, which is detected in the EMG. And this is the voluntary cue. It indicates the patient when to start and stop the exercise. So during the first 3 seconds, the patient will have a voluntary trial session for 3 seconds. If the EMG threshold is reached, the robotic exoskeleton will take over the movement. If not, it will again start from 0. So the device is very modular and flexible by the small change in the mechanical design in 1 bar, which it can also give another movement, that is a wrist extension with finger extension as well. So the device was counteracting the flexure hypertonia. It was voluntary triggered. It was, you can say it as a customizable physiotherapy. And the patient took interest in operating it because it was a very user-friendly and simple device. The multiple repositioning of the hand was also very easy. And it was just 2.3 kgs. So we did the pilot testing. We screened more than 500 patients, out of which only 27 patients were recruited, was randomized, and pre-therapy data was collected. We included stroke patients with cortical and subcortical infarcts involving the motor pathway. So the 27 patients were divided into 2 groups, physiotherapy group and the robotic group. Both were given 45 minutes of therapy per day, 5 times a week for 4 weeks. It means 20 sessions was given to the patient. And then post-therapy data was again collected. In the post-therapy data, there was also one additional self-designed subjective questionnaire feedback, which asked the patient about the comfort, individual operation, interactive nature, duration, fatigue, and pain during the exercise. So patient found it to be simple, interactive, and user-friendly, and most importantly, safe. Its compactness, lightweight, and portability makes it suitable for home-based exoskeleton therapy, saving time and money for the patients. We also used a system usability scale, which is a standard scale used across the industry for novel devices. So this also scored 85, reflecting a promising scope of acceptance and usability in the clinical settings in Indian scenario. So the patients were comfortable in donning and doffing of the exoskeleton and individual operation with the minimum assistance of the physiotherapist. So patient took only as much as 69 seconds and 41 seconds to wear on and wear off the device on their own with the help of unaffected hand. So coming to the results for the clinical scales, the x-axis shows the physiotherapy, the control, and the robotic therapy. Y-axis shows the scales of the clinical scales scores. So coming to the modified Ashworth scale mass, which is the measure of spasticity of a wrist joint. So we saw that robotic therapy group was effective in releasing spasticity at the wrist joint. From pre-therapy to post-therapy, the modified Ashworth scale was very reduced. Similarly, active range of motion was also evaluated using goniometer. Here also robotic therapy showed significantly higher improvement over control group from pre-therapy to post-therapy as compared to the control. We also took Fugl-Meyer scale, which is a sensory ability and functionality also, and which measures, it is a very coarse measurement, which measures the sensory motor functionality. So with respect to the physiotherapy group, the robotic therapy group showed a very significantly higher improvement. Fugl-Meyer scale is for whole arm. So we segregated it into two parts, the shoulder elbow and the wrist hand. So we noticed that the wrist hand, which is actually engaged in the training with the robotic exoskeleton, showed significantly higher improvement in the robotic group as compared to the control group. Coming to the cortical excitability, which is the objective scale of the brain data, like neurophysiological parameters were acquired using transcranial magnetic stimulation. There were two parameters, resting motor threshold and MEP, motor evoked potential. So resting motor threshold is defined as minimum intensity of TMS over the primary motor cortex area required to elicit a motor evoked potential. So in simple language, you can understand RMT is input and MEP is output. The minimum intensity which is required to acquire output of motor evoked potential in the muscles. So in case of stroke recovery, the RMT should decrease. The input required to excite the neurons is will be relatively less as compared to the pre-therapy. So robotic group therapy significantly decreased, showed a significant decrease in RMT as compared to the physiotherapy. And also you can see here motor evoked potential remained literally the same from pre to post in the control group, and robotic therapy showed a significant improvement. So it is very interesting to observe that the effect of physiotherapy was limited to just the clinical scales or the peripheral arms. Rather, the effects of robotic therapy reached the brain as indexed by the RMT and the MEP. We also took the unaffected, like the stroke affected side and the stroke unaffected side. Both we took both sides, RMT and MEP, and through that we calculated interhemispheric RMT symmetry, which was also reduced and which also towards the normality. It was RMT asymmetry came towards the normality. So this was also published in JNER. We also did a very interesting case report of a patient with right hemisphere stroke with 9 years of chronicity. So pre-therapy to post-therapy, there were various clinical scales which showed reduction in disability. Pre to post therapy, the Ibsilation RMT was decreased by 6% and the MEP was increased by as much as 90%. So also in the functional MRI, in the 3 Tesla achiever, we can see that there is a considerable decrease in the activity because when the patient has achieved the skilled motor performance, there will be a very less activity, very less number of neurons will be required to do the activity. It is similar to the hypothesis that in the healthy subjects, if we are doing the left hand and the right hand, dominant hand and the non-dominant hand, the right hand, which is the dominant hand, will show a very little activity in the neurons as compared to the non-dominant hand, the left hand, that will show a more activity. So if the patient has improved a little bit, it will show increased activity. But then the patient has achieved skilled motor performance, it will show decreased activity in the primary motor cortex. And also the laterality index of these two area, the pre-central gyrus and the post-central gyrus, was also decreased too, and it normalized to 1. Also, you can see the activities in the left cerebellum hemisphere. It was very less as compared to the post-therapy. So this was also published in Frontiers in Neurology. So we did not stop here. There was the EMG acquisition device, which was replaced by the MyoVer, simple MyoVer, which is just 50-gram device. So this was all based on the patient's feedback. We made changes in the CAD model and hence printed it again. So based on this work, I'm proud to share that we have also established Center for Advanced Research and Excellence in Disability and Assistive Technology, CAREDAT. Professor Amit Mehdiratta sir is a supervisor from Biomedical Engineering at IIT, and Professor M.V. Padma Srivastava ma'am and Professor Senthil Kumaran sir from NMR, Nuclear Magnetic Resonance, is supervisors from the AIMS. So this center is first of its kind in India, where both the leading engineering and medical institutes has come together for the development and clinical validation of the novel techniques of rehabilitation. It also aims to stimulate and foster a sustainable, innovation-driven and interdisciplinary research, most importantly. So this will provide an umbrella of artificial intelligence, machine learning, robotics, virtual reality, IoT, etc., for solutions for neurological disorders such as stroke, cerebral palsy, brain injury, spinal cord injury, etc. So the vision of the CAREDAT includes the clinical validation of this low resource setting beta prototype of the device as a home-based model with telemonitoring and tele-neurorehabilitation on more than 200 patients with stroke. This exoskeleton can also be synchronized with the brain stimulation, that is a transcranial magnetic stimulation, to stimulate the brain in a closed-loop Hebbian stimulation approach for better clinical gains. This also has, the pilot study has also been done on this, and the sensory motor gloves will also be designed as a vision of this CAREDAT and clinically validated too. Another vision of research is to answer a few questions using fMRI, that left stroke or right stroke will show better gains after which intervention, so that we can tailor the clinical intervention according to the stroke patients, whether they are left affected or the right affected. Another vision of this of the CAREDAT is to design the, augmented reality, virtual reality tasks for the distal joints of the patients. Here a patient has to navigate within the pathway without having to touch the obstacles with the joystick motions. These joystick motion will provide wrist extension and wrist flexion, finger extension and finger flexions as well. So at CAREDAT, we are also open to the industry as well as academic collaborations. And I believe for the biomedical research, collaboration is the key, and I'm thankful to each of my mentors without whom this work would not have been possible. Thank you. I will be happy to take the questions.
Thank you, ma'am, for giving us insights on how robots have the potential to provide exercise therapy in a reproducible manner for stroke survivors. It was really interesting to learn about the positive effects of robotic exoskeleton on training stroke patients. Thank you for joining us today, ma'am.
Thank you. The pleasure is mine.
Over to Tuhina.
Before we part for the technical session, we have a few instructions to be conveyed. The technical sessions for the day, tracks 4, 5, and 6, will begin at 11 a.m. today. The meeting links have been shared, and the other instructions have been communicated to the respective authors by the session in charges of the tracks. In case of any queries, please contact your respective track team leaders. Following the lunch break, we will continue the keynote session at 1 p.m. The keynote sessions speakers for the afternoon will be Dr. Rahman Yaz Malik, Sheriff, Dr. Sean Joseph Smith, and Dr. Renu John. Thank you all for joining us in the morning session of the keynote speakers. And the keynote sessions will be conducted through the same link, and the link will be recurring and will be used for all the keynote sessions for today as well as tomorrow. And to all the participants, I wish you all the best, and I hope that you have a very constructive experience at the day 2 of ICBSII 2022. Thank you.